All right, I'd like to call this meeting to order of the Committee to Study Long-Term Managed Care. I am Representative Jim Kofalt, representing Hillsborough County District 32, Wilton Temple, and New Ipswich. Representative Lucas, do you want to introduce yourself?
With pleasure. I represent Campton, which is Grafton County District 7. I'm also on legislative appointee to the New Hampshire Commission on Aging.
Yes, good afternoon. My name is Jay Markell. I represent Rockingham County District 18, which is Atkinson. And thank you for coming here today.
So just to give people, this has already gone out as a notice, but it'll show up in this week's calendar. I wanted to give people dates and times for our next two meetings. We are going to be meeting on Wednesday, September 24th at 2 p.m. and then again on Monday, September 29th at 10 a.m., presumably here in the same room. My expectation is, since the committee's report is due on October 1st, I have yet to determine whether that needs to be a preliminary report or a final report. What I'm expecting is that we will digest information from testimony in these first two meetings between now and next Wednesday. We may take some additional testimony next Wednesday, and probably will have a need to ask questions of the folks from DHHS. But the 24th will likely be an opportunity for us to start to dig into our options and conclusions. And then the 29th is where I think we will be, hopefully reviewing some of those conclusions and coming to consensus on what kind of, what the report will look like and how we move forward. Again, thank you for being here. First order of business is going to be to review and approve the minutes of the previous meeting. Having had an opportunity to look at those, are you prepared to vote to approve those? Okay, yes. All in favor say aye.
Aye.
All opposed and abstentions. Okay. Minutes from the previous meeting are approved. And with that, we have 4 organizations signed up to offer testimony today. As usual, I will invite DHHS to chime in where appropriate. And at the end, I will ask if people have anything that they would like to add. So if there's anybody who hasn't signed up to speak but would like to, you will have an opportunity. Furthermore, if there's testimony that if you've already given testimony and you feel like there's something that calls for clarification or a response, I don't necessarily want to get into a back and forth debate on things, but I do want to give people the opportunity to raise concerns if they have them, and make sure that the committee gets all of that information. So with that, I would like to call forward representatives from AmeriHealth Caritas.
Thank you.
One goes to her staff. I just need to.
And so if you could, just for the recording, just make sure your mic is turned on. I believe it's the button on the right will light the red light, and that's an indication that it's on. And then for the record, if you could state your name, and I'll ask everyone to begin by stating your name, and then if it's unclear, spelling your name would be helpful. I would also ask, there may be moments when Representative Lucas asks you to repeat something or slow down a bit, because she's trying her best to capture a lot of very detailed information here. So,
thank you. Good afternoon, Chair Kofalt and members of the Committee to Study Long-Term Managed Care. My name is Sharon Alexander. That's S-H-A-R-O-N. last name Alexander, Alexander. I'm president of Long-Term Services and Supports, LTSS, Solutions at AmeriHealth Caritas. I also serve as chairman of the National Managed Long-Term Services and Supports Health Plan Association, which is a national trade association of the leading MLTSS plans in the country, who serve approximately 2 million individuals who receive Medicaid long-term services and supports. I appreciate the opportunity to testify here today as you consider transitioning from a fee-for-service to a managed LTSS program. A little bit about AmeriHealth. Since 2019, AmeriHealth Caritas New Hampshire has been serving individuals in New Hampshire with the current membership of over 48,000 individuals. Through our contract with the New Hampshire Department of Health and Human Services to provide statewide Medicaid healthcare and prescription drug coverage through the plan. We're known in New Hampshire for going above and beyond the minimum contractual requirements, starting with a value-added dental program provided prior to it becoming a state requirement, and afterwards for our HOPE Squad Youth Suicide Prevention Program conducted in partnership with the Conval School System, the Family Preservation Program in concert with Family Resource Centers, and ongoing support for over 70 community-based agencies here in New Hampshire. Through our parent organization, we serve about 5 million low-income and chronically ill individuals in 13 states and the District of Columbia. In terms of the LTSS population that we serve who have complex health and social needs, we serve those individuals in 5 of our states, Pennsylvania, Delaware, South Carolina, Michigan, and North Carolina, covering about 105,000 lives. Our Pennsylvania plan is one of the largest LTSS plans in the nation, serving 92,000 individuals with LTSS needs, plus another 81,000 individuals who are dually eligible, meaning they qualify for both Medicare and Medicaid. They're also included in that plan. Nationally, in terms of the MLTSS landscape, MLTSS programs are, as you know, capitated, quality-driven, Medicaid managed care models that coordinate and deliver health and long-term services and supports to individuals with disabilities and older adults needing assistance with daily living, such as eating, bathing, dressing, toileting. These programs use health plans like us to provide a comprehensive array of services such as personal care, adult day care, skilled nursing services, home-delivered meals, respite care under a fixed rate. The goal is to promote community living, improve care coordination, and ensure person-centered care for participants with complex health needs. As of 2025, so currently about 26 states in the country operate managed LTSS programs in which state Medicaid agencies contract with managed care organizations to deliver LTSS, up from about 8 states in 2004. And there's 2 additional states, in addition to New Hampshire, that are also considering LTSS. And although the growth of this has really been in the last 10, 15 years, many of these states have been operating these programs really for decades, like Arizona, Massachusetts, Florida, and Texas. So it's not, in many states, they aren't new programs. In terms of LTSS in New Hampshire, what we know here is that LTSS services are primarily provided in nursing facility setting here in New Hampshire. According to the New Hampshire Fiscal Policy Institute, New Hampshire ranks 37th in the expenditures of home and community-based services as a percentage of total Medicaid long-term services and support expenditures, lower than all the other New England states, and there's only 11 states that are equal to or less than New Hampshire. This results in over crowding of nursing homes, long wait times to get a bed, increased staffing pressures, and most importantly, our family members' preferences for remaining in their homes and communities are not being honored. So this committee certainly has the opportunity to broaden choices for constituents, reduce fragmentation of care, and improve access to home and community-based care through managed LTSS. So some of the key advantages that we've seen in our programs that could possibly occur here in New Hampshire. The first is better care coordination and outcomes. Through a single point of accountability, MLTSS plans integrate services across medical, behavioral health, and social support systems, while also improving care coordination and community alignment. A dedicated care manager working with an interdisciplinary care team is assigned to each LTSS participant to assess needs, coordinate services across medical and non-medical providers, monitor changes in condition, and act as a central point of contact for the individual and their care team. Over the last 4 years, on average, 9 out of 10 LTSS members surveyed in our Pennsylvania plan found that their service coordinators have been very helpful. That same plan met or exceeded the statewide goal of 95% for completion of comprehensive assessment and person-centered care planning. The second advantage is improved accountability and quality. MLTSS plans have standard quality benchmarks established by the Centers for Medicare and Medicaid Services, CMS, and other quality measurement stewards like NCQA, National Committee for Quality Assurance, to measure and improve the quality of care for beneficiaries. And in most cases, states will tie performance-based incentive payments for achieving specific quality targets, such as transitioning members from institutional settings to community-based settings. Such states contract with MLTSS plans to report on these and other quality measures. And some of those other measures can include assessment and care planning, timeliness of services, member satisfaction, and quality of care standards. States like Pennsylvania, Wisconsin, Virginia, Tennessee, and New York, among others, all have really notable quality-based payment programs, which have led to more consistent service delivery, greater transparency, and improved overall care for the beneficiaries. The third benefit is sustainable spending and predictability. Medicaid LTSS expenditures in New Hampshire already consume a large share of the state budget, as you well know, and costs are projected to grow steeply as the population ages. By adopting MLTSS, New Hampshire can achieve budget predictability through established fixed actuarial sound capitated payments, shifting the financial risk to managed care organizations while ensuring sustainability for the future. States also use LTSS programs as a way to rebalance their LTSS systems from institutional settings to a more cost-effective integrated community setting appropriate to a person's needs. From our most recent experience in Pennsylvania between June of 2020 and June of 2025, there's been about an 8% increase in participants transitioning from an institutional setting to a home and community-based setting. And in 2024, 94% of those individuals who transitioned actually remained in their community setting of choice for 6 months or longer. So they were able to achieve sustained community living. Home and community-based services are also typically less expensive than nursing facilities for each enrollee funded. And by prioritizing home and community-based services, states can potentially serve more people with the same budget. It's important to note that even as MLTSS focuses on expanding home and community-based services by providing alternatives to institutionalization, nursing facilities do remain an integral and essential part of the MLTSS program and continuum of care. For individuals who require a level of medical and rehabilitation care that cannot be safely and effectively provided in a community setting, nursing homes remain a vital and necessary option for many families. And finally, improved access is another benefit. Our MLTSS plans have demonstrated improved access to home and community-based services. Our Pennsylvania experience has shown that 94% of our participants who have in-home personal cares included as a part of their care plans have services initiated within 7 business days of enrollment with the plan. Our MLTS plans can also offer more flexible and enhanced benefit packages. We offer a caregiver support program for caregivers of individuals with LTSS needs. They have access to care advocates that can help them navigate the complexities of caring for a loved one. And we've also had a transition benefit, which has supplemented state benefits to help people, again, transition safely from an institutional setting to a home-based setting. And MLTSS programs have also added additional populations over time. Such programs typically offer target people who are age 60 or 65 and older and individuals with disabilities, but states are increasingly enrolling individuals with intellectual or developmental disabilities into MLTSS. 3 states in particular, Iowa, Kansas, and Tennessee, do require individuals with IDD to receive all their Medicaid-funded services, including LTSS, through their managed care programs. So there's early experience, but it's a more recent population that has been folded in to LTSS programs. We offer some best practices to support a transition, and from our experience in working with many states, we feel like it does require thoughtful analysis and detailed program design, strong state oversight, and appropriate accountability mechanisms. The more recent states, Pennsylvania, Indiana, and Virginia, offer some important insights into how to go about transitioning to a managed LTSS program. We offer a few of those here, and I know I've probably exceeded my time, so again, given the complexities of the program, we recommend that the committee conduct further analysis and study of this issue to assure that the consumers and providers and plans are that the issues are heard, needs are addressed, and it's fully assessed. We look forward to continued participation with the committee and are available to answer any questions and provide any additional information you may have. Thank you for having us.
Thank you. Questions?
Yes. Thank you for a very good presentation. I'm curious about the programs that you've mentioned that have been implemented with your experience in Delaware, Iowa, Kansas. And can you tell us about how those programs are administered, and can you tell us a little bit about what the cost structures are in those, if you know what they are?
So we operate in Pennsylvania and Delaware. We don't operate, just to be clear, we don't operate in Iowa. I was just pointing out some other states that do offer MLTs. We don't operate in all those. But the structure is the state Medicaid agency contracts with managed care organizations. Okay. They reimburse us on a fixed capitated actuarial sound, rate structure. Mm-hmm. And we receive those dollars on a month-to-month basis, and we are required to provide that entire continuum of services, okay, including LTSS services. So whether that individual is residing in a nursing home or if they're living in their community, it's one rate. Okay. And that's what we receive. We're held to contractual standards through the annual agreement, and we provide reporting on quality metrics, and the state provides pretty detailed oversight and monitoring of our work.
Okay, thank you.
Mm-hmm.
Thanks for your presentation. I jotted down a couple of questions between notes. So you mentioned a long-term services and support coordinator. Mm-hmm. Do they work on things like transportation needs? Yeah. in the situation where someone has been in an institution or hospitalized but is ready to go to a different setting, do they look into housing arrangements?
Mhm.
Is that all part of the
It is.
duty?
It is part of the duty, and in fact, a best practice that we have had in some of our programs is that we'll supplement the work of that care coordinator. Some states call them service coordinators, and with a person that's called a housing coordinator. So that housing coordinator will supplement. So if someone has indicated that they are interested in transitioning from, nursing facility setting into the community, it doesn't happen overnight by any stretch, right? So you do need to understand thoroughly what the needs are, what the supports are that individual needs, and you need to locate housing that's going to be suitable and acceptable for that individual and for their family if there is family involved. So yes, that is definitely, and transportation obviously is a key part of that as well.
One more.
Oh, I'm sorry.
You indicated that there's a presence in Delaware and Pennsylvania.
Yes.
So I think that's could be very enlightening for us because Delaware is a small state.
Delaware is,
with a small population. And then Pennsylvania, like New Hampshire, has very densely populated areas and then very rural areas. Can you elaborate on maybe some of the differences between what your company has found in the densely populated versus the rural areas of Pennsylvania?
Yeah, and I have to say, I served as Secretary of Aging in Pennsylvania, so I'm very familiar with with the landscape in that state, from the urban pockets to the very rural nature of the center part of the state. So the issues in the rural areas certainly are compounded due to some lack of providers, availability of workforce. I mean, that's an issue statewide, but there definitely are challenges from a transportation perspective. So what that has led us really to do is to really innovate. You try to come up with programmatic solutions and innovations to try to bridge that, bridge some of those gaps. I mean, we've been able to do some enabling technology to just help supplement some of the things that maybe we couldn't have done otherwise. We've had a strong movement to self-direction, which is the ability of family members to become paid caregivers for their loved ones to help with the workforce problem, which is really exacerbated in some of our rural areas. So we've been able to try to advance, some of those efforts as well. So it's really, in our Delaware experience, that Delaware, it's a Medicaid plan of about 66,000 members. We have 3,600, individuals who have LTSS needs. It's a very small state. It only has 3 counties. There's definitely common themes in the program, but it's a small numbers. I mean, we have 3,600 versus over 90,000 LTSS members, right, in our Pennsylvania plan. But we work side by side in terms of the care delivery process. Our infrastructure and systems are aligned, but there are unique requirements. You want to make sure that you have a good scalability in terms of the program. And serving, several thousand people certainly get you to some sense of scale, so that the investments that you make from a technology, from an infrastructure, from a care team, and from some of the programmatic solutions, can be applicable across.
Thank you.
Oh, thank you. Thank you for taking this question. Do you have any information that you could provide to us on the differences between the costs on the capitation model that we've discussed here, at least for long-term LTSS versus nursing home, how that's going to play out?
Yeah. We can probably provide information that's available publicly, right? So there is our actuaries, each state has their own actuaries that work with the health plans to develop rates. So we wouldn't share necessarily our specific rates, but there is it's called a rate book. So every year a rate book does get published. You can go out and look on the website now, and you'll be able to see what some of those numbers look like on a broad basis. It's developed understanding the characteristics of the population, the geography of the population, et cetera. So that you'll get a good sense from even just pulling down the rate book that is available publicly. It's on Pennsylvania's website. I believe it's on Delaware's website. It's probably on other states' websites.
Okay.
Yeah.
Thank you.
Yeah.
So I had a couple of questions. One, so of the states that you're operating in on a managed care model, what's the composition of the populations you're serving? How many are sort of elderly versus DD versus, what are the various, what's the composition of those?
Yeah, most of them are, our Pennsylvania plan targets individuals 21 years of age and older, as well as individuals who meet the nursing facility clinical eligibility, right? So New Hampshire sets a criteria to determine that someone actually meets LTSS. So our Pennsylvania plan meets that as well, and it's the same population for Delaware. The interesting thing about Delaware, though, is that we do serve the IDD population, but not their LTSS needs. So we service their acute and healthcare side of their needs, and we coordinate with the waivers, the HCBS waivers are carved out, and we'll coordinate with the waiver case managers, if you will, for those home and community-based services. So we don't have responsibility. We're not capitated for those. And that's another way that states have wrapped in those populations. They've sort of eased it in by covering the acute care side first.
Okay, thank you. So you were also referring to care management, and I'm just wondering if you could sort of explain the distinction between case management and care management, and sort of what is the if I had an elderly parent who had was eligible under long-term managed care for support services, what would they expect in terms of direct contact with somebody at your organization?
Sure. So there would be a care manager who is typically a professional, a social worker or a nurse or another human service professional, but the state would set standards that you would want for that kind of person. And that's usually articulated in the contract. So a social worker or a nurse would be assigned to your mother, and she would see her at least once a quarter. So she would do a comprehensive assessment of all of her psychosocial needs in her home or wherever she is residing, get an understanding of what those needs are, prepare a care plan to identify what the priorities are that they've jointly agreed, to focus on and work on, and then at least see her quarterly. And then during those other times, those other months where you might not have a face-to-face visit, you would have an outbound, telephonic call. Now, if something has happened in between, if there was a hospitalization or some sort of what's called a trigger event, then that would necessitate another visit from the care manager who would reassess needs. Perhaps there was a hospitalization, maybe a fall or something that would have happened that would necessitate a reassessment and then an update to the care plan.
Okay, thank you. So I guess my other question, I think you've already answered, which is around quality, sort of the quality assessments, and
Yeah.
you're saying those are defined by CMS.
Yeah, so
Can you talk a little bit more about sort of what are they looking at, and how deeply do they look at those
Yeah.
quality standards?
So what typically happens is that states will specify the quality metrics that they would want LTSS plans to adhere to. So, and states can leverage a set of there's actually an HCBS measure set it's a voluntary measure set. It's not required by CMS for the states, but it is certainly a benchmark, a set of benchmarks that states can use and incorporate those into their contractual relationships with the health plan. So it's looking at things like timeliness of service initiation, at the completion of comprehensive assessments, updates to care plans, sharing those care plans with the PCPs, and then it looks at things like falls, fall risk. It can, it's a whole host of some of our states, there have been particular themes or issues. So like, for instance, Pennsylvania set targets on transition rates. So they wanted to really focus on rebalancing the LTSS system, and they set a benchmark for each state, for each MCO, contracted MCO. And we had to either meet or not meet, but we were gauged against that benchmark. So there is a set of a measurement set associated with LTSS and home and community-based services. So the state, New Hampshire, would not be starting from square one at all. There's certainly a really thoughtful foundation of metrics available. The state would just prioritize, the metrics that they would want, to hold the MCOs accountable for.
Okay. Good. Other questions?
Not at this time. Thank you.
All right. Thank you so much.
Thank you.
All right. Next, I'll call forward Community Services Network. And again, if you could just start out by stating your name and spelling it if appropriate. Wow, you brought reading material. Okay.
How many extra copies? One to a staff person.
Yeah, and I'll take one for
Thank you.
Senator Abard as well. Thank you.
Representative Cofalt and committee members, thank you for taking the time to listen to our testimony today. For the record, I am Marissa Berg. I am Executive Director of Community Support Network Incorporated, or CSNI. We are the association of New Hampshire's 10 developmental services area agencies. These agencies are the only entities in the state that complete designated area agency delivery system functions. And certain other functions under contract on behalf of the Bureau of Developmental Services. We wanted to address the managed long-term care discussion from the lens of sort of the other three waivers, the developmental disability, acquired brain disorder, and in-home supports waivers. So 3 of the 4 home and community-based care waivers, these specifically supporting individuals with developmental disabilities and brain injuries. As you know, the services that are provided under these waivers fall within the scope of the area agency system. This system was developed many, many years ago with the closure of Laconia State School. Families at that time wanted independent nonprofits to be involved with the placement of their loved ones out in the community. And these area agencies continue today. The inclusion of developmental services into managed care is a topic that has been discussed several times before. most notably in 2011 when managed care organizations were new to New Hampshire, and then again around 2016 and 2017. And over the years, CS&I has collaborated with the department and engaged several national consultants to enhance our understanding of managed care implementation in a state as small as ours. Today I've shared binders containing an important, although not comprehensive, selection of these analyses for your review. The most recent studies from 2017 and 2018 demonstrate clear evidence that possible savings from managed care have already been realized for New Hampshire waiver participants on the DD, ABD, and IHS waivers. And you'll see several studies and references in these binders in front of you. In 2016, the state contracted with Milliman, an actuarial firm, to conduct an analysis that included projected savings if the state were to move to step 2 of managed care. And the findings from this analysis were clear, and I'm quoting what was presented. Milliman was asked what savings could be expected in the New Hampshire DD and ABD waivers, since there had already been a 100% transition from institution-based services to home and community-based services. He stated that there were no available savings based on moving the site of service delivery from institutions to HCBS. This is the primary savings opportunity identified from national data. The state of New Hampshire continues to focus exclusively on supporting developmental service waiver participants in community-based settings. As recently as 2023, the State of the States project at the University of Kansas notes that the average per person waiver cost in New Hampshire is $66,400. This compares with $70,500 nationally. New England's averages are even more substantial. In Massachusetts, the average is $117,000, $117,000 in Maine, $127,000 in Connecticut, $99,000 in Rhode Island, and $82,000 in Vermont. And if you didn't catch all of that, at the back of your binders, there's this report. I apologize, it's not in the index, but I felt it was really important for you to see. That is information specific to New Hampshire that contains the $66,400 number.
Okay, and I'm going to ask you to repeat one of those numbers, and I'm sure it's
Sure.
in here somewhere. But you said $66,400 for New Hampshire, and then you gave a national number, and that's the one I missed.
Okay, that's $70,500, and that's the national average.
All right, thank you.
Following the 2017 and 18 decisions to pause move forward into managed care for waiver participants, New Hampshire began conducting some pretty significant systemic changes. There were 2 concurrent activities that were happening at the same time. The first were changes that brought the state into compliance with new measures to prevent conflict of interest. Those were required by the Centers for Medicare and Medicaid, CMS. A parallel system strengthening project was also happening, which was coordinated by the Bureau of Developmental Services and DHHS with the support of Alvarez and Marsal and other consultants. And part of this system strengthening work included developing rates for services. The department included these in their budget request for the current biennium, however, they were not funded. And it might be premature to undertake any significant system changes before these system strengthening efforts are even underway. So New Hampshire's community-based system has been shown time and time again to be a cost-effective way to support individuals with disabilities. Supporting individuals in the community enables the delivery of higher quality services, greater autonomy in choosing the services a person receives, and person-centeredness in the way a person decides to live their life. In 2011, families rallied intensely against the inclusion of New Hampshire DD services in managed care. They were pushed for the separations of steps 1 and 2 in the implementation of these structures. And I would ask the committee to consider whether step 1 was successful, met expectations for cost savings, access, and quality of care, and that the committee might consider pausing to allow time for the work that's already been done to take effect through the system strengthening process. New Hampshire citizens with developmental disabilities and their families have always been clear in the past and continue to be that they want local control and a focus on accessibility to high quality services in the community. Thank you for your time.
Well, this is a lot of information to absorb, and thank you for what is obviously very comprehensive material here. Can you tell me what your criteria are for your using for individuals with disabilities living in the community?
The criteria for accessing the waivers, or what would constitute a community-based setting?
Actually, both questions.
Okay, so for the developmental disability waiver, well, actually all 3 waivers, there are specific criteria of an individual needing to experience some level of functional impairment in community-based living. So they could be things related to activities of daily living. You know, there's specific qualifiers that are included in regulation that qualify people for those services. But a lot of it is really based on functional impairments. So it's the qualifiers for developmental services. Also of note that's a little bit different is when an individual is found to be eligible for developmental services, they are eligible for life. It is not, there are 3 different sort of categories. There's conditionally eligible, and that is for children who may or may not experience functional impairments when they get older, ineligible or eligible. So once a person is found eligible, it is not sort of in and out. It is, you know, that person is eligible for life.
Okay. And just a follow-up question. Okay. So do you also have area agencies involved in this program, such as that may be involved with this administration of this program?
The administration of waiver services?
Waiver services, and also where these individuals meeting the criteria would live.
So the area agencies, part of the system strengthening process and the conflict of interest is there is a sort of separation now of functions. So if you'll see at the back of your binders, there's a list of what are called DADS functions. That's the list of area agency functions. Okay. Area agencies can also choose to provide direct services. So many area agencies also operate housing. They have different direct service programs that they offer. There's not required of them. They choose to do that. They also could choose to provide service coordination. That is, again, it's an option. Area agencies can choose to do that as a line of business. But the ones that are required of them are the DADS functions that are listed in here and the services that are provided under state contract. And each of those contracts looks a little bit different depending on the area agency.
Okay. One more follow-up question. Thank you, sir. So this sounds really good. If anybody has criticized any of these things, can you tell us what the nature of the criticisms were and how you would respond to it?
The criticisms of
these programs.
The waiver services?
Yeah.
I think that all waiver services, there was a mention previously of workforce access to services is really, really challenging. And I think in a state where, you know, over many, many, many years, you know, people who are involved recognize that it is imperative that there be cost effectiveness to these services. We have been very happy to advocate for families and alongside families to ensure that there's no funding wait list. But we recognize, I think, as a system, how important it is to make sure that the state of New Hampshire feels that these services are valuable. So there's that balancing act of making sure that families can still access workforce, to make sure that they have direct support professionals, and that there are, homes and residences that people can access when they need them. Balancing that with making sure that cost-effective services are being rendered.
Thank you.
So I just want to be clear. So that when you talk about system strengthening, you're talking about sort of there's sort of a BDS did a redesign of the billing, and okay.
Yes.
I'll ask you a question similar to what I asked before about sort of what does it look like if I had a relative who was, qualified for Medicaid and was elderly, and I mean, I know you've been talking about DD and ABD, so you could extend it to them as well. Sort of what does the coordination of care look like? How often do they hear from somebody? Who's really overseeing sort of overseeing their entire care plan?
So I can speak to, sorry, I don't know if people can hear me. I can speak to developmental services. I couldn't necessarily speak to individuals who are elderly unless they also had a developmental disability. So this would extend to them. Depending on what you wanted for services, there's certainly a wide range of services that are needed. There are some individuals who only need minimal services because they live in the community. Maybe they have their own apartment. Maybe they just need somebody to come in every so often and help make sure that they have groceries in the fridge and they have, they're taking their medications. And so there's sort of that end of the spectrum. But then there's also 24/7 care, where you have shifts of staff who are coming in and helping this individual. Maybe they have intensive medical needs that require nursing, or intensive behavioral support needs to help prevent them from engaging in self-injurious behaviors. So there's a pretty wide spectrum. Across the board, though, the minimum is everybody gets a service coordinator. They can choose their service coordinator too, so they don't have to go to the area agency. They can choose to have a service coordinator, so long as that agency is enrolled with Medicaid to provide that level of service. Those regulations are HEM 503 that guide service coordination for developmental services. They can expect that at a minimum, they will have, for I think all services at this point, they can expect a minimum of quarterly in-person visits and monthly phone contact. It is typically much more than that, particularly for individuals who are in residential settings, because these service coordinators are frequently in contact to make sure that the individual has what they need.
Okay. My understanding was that there were discussions going on at some point about moving to I don't know if it would be a capitation model purely, strictly speaking, but more of a sort of a capitation model based on sort of defined categories of need, as you just outlined. Some people may be very high functioning, others need 24/7. So as far as I know, that has not been rolled out, has not been moving forward, unless you tell me otherwise.
Are you referring to the rate bands that had been discussed several years ago? Okay, I believe that's on pause, but I would say hold that until the department maybe.
I thought you might be able to help me know for sure. The other thing that I think is a great concern for many of us is the workforce question. You raised that, and I guess we heard some concerns on Friday about the impact of the managed care model on providers who are already struggling. I wonder if you could comment on that, and particularly comment on that, include some discussion around sort of different parts of the state, because, obviously it's very different, different needs, different sort of population density, and presumably a different, workforce and availability of providers. So if you could comment on that, I'd appreciate it.
So I don't think that I'm going to be able to offer anything that it sounds like you don't already anticipate, but certainly the workforce crisis up north looks very, or even out toward Keene and the Monadnock area looks very different than, say, Nashua or Manchester. It does not mean that it's any better or worse. Both of them really have their own sorts of struggles. I think that there were many providers and area agencies that were very excited to see rates put into place because, with the hopes of being able to entice more workforce, through not just increases in the rate of pay, but also, we've seen a lot of discussion about how do we creatively draw people in. State or area agencies have also, there's been several who have been participating in different workforce initiatives, a lot of them funded by ARPA dollars. And some of those have been successful. So we're really focusing on trying to be really creative in bringing people into this, not just for thinking about some of the older sort of techniques or things that were used, thinking about how do we make sure that people understand that this is a career. How do we make sure that their needs are being met no matter where they are in the lifespan? How do we make sure that people understand that this is a job where you really get to care about people, but it's also a lot of fun. So we're trying to, as a system, come at this from multiple different angles to make sure that we really understand the workforce and how to make sure that people get what they need for services.
I just have a question that is fairly broad, and you may not have an answer, but I'm interested anyway to ask. A significant percentage of unhoused are 55 and older. Does your organization also work to provide them with the same services that you're describing for people who are in housed arrangements?
So we do not have, I don't have any statistics, but I could say anecdotally, we really don't have a lot of unhoused folks in the developmental service system. Typically, we are able to wrap around individuals who may be new to our services. Sometimes folks will come to the emergency room and there's a realization that additional services in the developmental service system might be needed. In that case, it would be sort of an all hands on deck situation to make sure that that individual was not unhoused. And we would all work together alongside the, individual or professionals from DHHS and from different entities to make sure that that individual was not in a dangerous situation. So I would say that we don't typically see that. That's not to say that there's not, for certain, there's nobody who's unhoused, but we typically have a pretty robust wraparound discussion to make sure that that individual is kept safe.
No.
Thank you very much.
Thank you.
Appreciate it. Next, I'd like to ask a representative from Centene to come forward.
Mr. Chairman, members of the committee, thanks for the opportunity this afternoon. My name is Chris Kennedy, Kennedy, Vice President of External Relations for Centene. Can you hear me okay?
Yes.
Yeah.
Yeah.
I want to go into a few items, and I promise I will try my best, first of all, not to be redundant from the presentation, the very extensive presentation from Amera Health Caritas. But just while it's fresh, I appreciated Ms. Bird's testimony, and I'd love to get a copy of that binder. I could probably learn a lot from it. But I did just want to, as a point of clarity, I think that the directive in HB2 around this endeavor is mostly centered around nursing facilities and that population. Dating back to, not to go into a history lesson here, but dating back to the inception of managed care, when the legislation was adopted, I think in 2011, when the initial program went live in 2013, yes, it was always envisioned as kind of a staggered approach toward implementation, with the long-term care populations coming second. I think if you talk to any number of commissioners of that department over that lifespan, most of them would have envisioned a bifurcated approach in terms of implementation of what we used to call step 2. So long-term care nursing versus DD, ABD. As someone who represents an organization that would very much like to see long-term care implementation into managed care go forward, I'd feel entirely comfortable even sitting here telling you I think there should be a bifurcated approach. I don't think you should do DD and nursing at the same time if you were considering recommendations toward that implementation. I think it should be very much a staggered approach, and one implementation should inform the other. So I wanted to address that, because we could get, so I think some of the statistics, and again, I don't have the citations in front of me, some of the statistics even from the 2016 Milliman report with respect to the exhaustion of cost savings, I think pertained exclusively to the DD side of the equation and not nursing. So I did want to just mention that as a point of clarity. Does that make sense? Yeah. So just a couple of things about Centene. First of all, we are one of the 3 managed care organizations currently serving the state Medicaid population. We have been in the program participating since the inception of managed care in 2013, and today we cover about 66,000 Medicaid beneficiaries under the existing program. We have about 140 employees locally based out of our offices in Bedford, New Hampshire. We have a robust network of over 10,000 providers, and one of the things I always like to mention is we talked about care management. About a third of our staff, about a third of our 140 employees down in Bedford actually are clinicians, either nurses or licensed social workers and the like. Our chief medical officer is a practicing physician. And so I think that's important to consider as we talk through this conversation. And I know Ms. Alexander mentioned, Caritas has extensive experience in terms of a variety of markets of implementing and administering long-term care. At Centene, our footprint in terms of long-term care across the country is fairly extensive. We're in 15 states and cover about 338,000 long-term care lives in those 15 states. They include very large states like Texas, Florida, Ohio. We're in Pennsylvania, and they include small states. We are in Arkansas. We're in Delaware, South Carolina, and the like. One of the things I will also note is, we spend a lot of time with our members trying to measure satisfaction. And so we do it here in New Hampshire. We do it in other markets where we engage with regulator-sanctioned satisfaction surveys. We most recently undertook such surveys in both Pennsylvania and in Kansas. And the average satisfaction rate, meaning the question being put is, were individuals either satisfied or very satisfied with their access to in-home or community-based services, was at 87%. And I'll tie that back, because I'll come back to why I think the conversation is important today, maybe even more so than it was when it was originally contemplated over a decade ago now, at least in New Hampshire. And as Ms. Alexander mentioned, over the last 20 years, more than half the states in the country have moved towards implementation of long-term services and supports into their managed care programs. So I think the inertia is very much behind fuller integration of these services into Medicaid managed care. But ARP did a study, or a survey, in 2024, about 3,000 adults 18 and over, and it found that 75% of Americans, 3 out of 4 Americans, would prefer to stay in their home as long as they can. when we talk about one of the benefits of incorporation of long-term care and building out that infrastructure in home and community-based services, I think you can't have the question without, or have the conversation without addressing the question of quality of life. It's what people want. And to the extent that there's an opportunity to help invest and build out and innovate within that infrastructure to give people what they want, I think that's a noble endeavor in and of itself. But why else is it important right now? Again, I go back to quality of life, cost effectiveness, population demographics, and New Hampshire, I will say, is a little bit behind in terms of integration of infrastructure for long-term care and also for the dual eligible populations. I think we may be now in the minority in terms of a state that does not have integration of long-term care into our managed Medicaid program. We're even in a smaller minority with respect to implementation of a vehicle for dual eligible members. And I will just note, and I appreciate this very much, that Director Lippman and the Medicaid Bureau did in fact include the opportunity for moving forward with what we call a DSNP duals model in this existing 5-year MCO contract. And we've had conversations to that effect, and we're very hopeful. And in fact, I think that the federal government is encouraging of moving forward with those kind of vehicles within managed Medicaid by 2030. So I think, that's important. I mentioned, the AARP study. Again, I don't think you can have this conversation without talking about quality of life. I mentioned that 75% of Americans want to be able to stay in their home as long as possible. That number gets even higher once you get 65 years of age and over. So again, I think that's an important portion of it. Cost effectiveness. We still think there are lots of opportunities for cost effectiveness, and when we cite that because, you could just look at the state budget and look at the expenditures in this area in the state budget and see where further integration, further extensive care coordination could make a difference. Working with members before they get to the point of decompensation and they have to go into a nursing facility, I think is a great opportunity there. But just pulling from a study, a report done in just last year, I think it was, from the New Hampshire Fiscal Policy Institute, and they cite state fiscal year 2021 most recently in terms of state budget appropriations. The average, per enrollee cost for those receiving care under the CFI waiver was $18,997 per enrollee. That same cost per enrollee appropriated from all sources, state, federal, and county, for enrollees for receiving care under a nursing facility was $98,111. That's from the Fiscal Policy Institute, specific to New Hampshire. So, I look at those numbers and I think that there has to be opportunity there. And I think a majority of states have in the last 20 years, seen the prospect of that opportunity and have moved forward accordingly. Then maybe one last item I'll touch on is as another reason why this conversation is perhaps more pertinent now than ever is demographics, is population. As New Hampshire ages, this is going to be a more and more pressing issue. The more we avoid having this conversation now, as we have to some extent, really for the better part of the last decade, the harder and tougher decisions we're going to have to make down the road. In the last census, the largest age demographic cohort in the state of New Hampshire were those ages 55 to 64. 200,000 individuals in the state of New Hampshire are ages 55 to 64. 2 in 5 Granite Staters are ages 75 or older. We are going to be facing a tsunami of both costs and care deficiency, access to care deficiency, if we don't look at alternative conversations about how we're going to handle the care of this population. And then I guess very lastly, I will just say, I mentioned, we're in the minority of states now that doesn't have long-term care incorporation into managed care. We're in even a smaller minority of states that don't have any vehicle to address duals, although again, I'm hopeful we're going to be moving forward with that option in the not too distant future. But I think it's important to note that this is possible. It was envisioned as part of managed care dating back to 2013. There are 6 million lives in the United States right now that are covered under long-term care, managed care within states across the country. 6 million lives. Again, over half the states in the country see that there is some opportunity there, whether, again, it's quality of life, whether it's cost effectiveness. And we think it's both. I will also just note the growing trend of, according to, again, the New Hampshire Fiscal Policy Institute, New Hampshire is the only state in New England and one of the minority states in the country that has an annual, or in our case, a biennial budget expenditure that dedicates more money to nursing facility care than home and community-based services. We spend more in the state of New Hampshire on nursing facility care than we do on home and community-based services. We are in the minority of the country on that. We are the only state in New England. Every other state, that dynamic is reversed. So with that, I think I'll stop, and happy to address any questions. But obviously, we very much think there is a prospect and an opportunity and a value in moving forward with long-term care. We acknowledge it can't happen overnight, but over the course of the last decade, there have been a lot of plans and processes contemplated and developed that we think could be instructive and useful, and we think it's time.
Would you be able to describe the difference in a future that involves managed care for long-term services and support versus the provision of those same services without managed care? What do you see as the advantages to the state of New Hampshire?
Well, again, you know, and maybe I'm naive, but I can't start the conversation without first saying quality of life. Again, our members, and you can find any number of surveys by just Googling them, that people want to stay in their homes. Quality of life is an important component of this conversation that I think gets lost, because we talk about, well, can you parse it out to dollars and cents, or can we parse it out to quality of care? And yes, I think you can do that too. I think there are enhanced opportunities for greater care management and thus greater quality of care. And I do think there are cost savings opportunities correspondingly. But I also think it's what people want. And I think that's critically important for people's individual autonomy, sanctity, peace of mind. I don't think you can put a dollar on that, but it's something to aspire to. But the other thing I will say, I'll just mention, Representative, because it just came to mind as you were outlining the question, is you can't have a conversation about access to care in this state or any other state without talking about the workforce issue. It's been mentioned so many times. And I think some of the cost savings that we could find in incorporation of long-term care into managed care, and some of the resources, frankly, that the MCOs can bring to bear, could offer us the opportunity to invest and develop and build out that home and community-based service care infrastructure that could greatly serve us down the line. We're not building any new nursing homes that I'm aware of.
Yes, a question? Thanks for your presentation. It's quite comprehensive. You had earlier mentioned that a few minutes ago about the difference in cost, which was obviously substantial. I was looking at 18,000 versus approximately 98,000. Okay. Are we, and the focus being that we spend more money on nursing homes than we do on the other alternative types of care, could the more money spent on nursing homes be a function of exactly how ill or how disabled people
Certainly
are?
it could.
And in other words, people who are in nursing homes because they simply need to be there?
Certainly it could. And let me be abundantly clear. I'm not sitting here telling you if long-term care were incorporated into managed care tomorrow, everybody in a county nursing facility is not transitioning to home and community-based services. Yeah. And again, that process, by the way, that assessment, it would be governed by the Department of Health and Human Services. They would be making that determination based on a comprehensive assessment that if they don't have developed, they certainly know how to do it. So yeah, I don't mean to misrepresent that at all. But again, I do think there are opportunities in building community-based services and infrastructure to put in place to prevent a person from decompensating, at least for a period of time, from a point of going into a nursing facility to begin with. I think those opportunities still exist.
Okay. Thank you.
So, so you mentioned the cost difference between somebody under the CFI waiver versus a nursing facility.
And those, just to be clear, those are from the Fiscal Policy Institute report, which cites New Hampshire expenditure data.
I
So
understand.
it's, yeah,
Thank you.
I want to generalize it. Yeah.
So I guess my question is, and forgive my ignorance, but under capitation program, is the state paying the same for both of those two theoretical patients? And what, you know, where, I mean, you presumably can't know where that number falls at this point, but based on your experience in other states, is it closer to the nursing facility number, or is it closer to the CFI number?
You know, I really couldn't say in any
Okay.
informed way.
All right, I can
know.
ask Mr. Lippman later, and maybe perhaps he'll have some insight into
Um,
that. I guess the other question is, really, I mean, I am 100% with you that the conversation has to include a discussion about quality of life. I think we've all seen that. We've seen that with our relatives. At the same time, you know, our nursing homes, our county nursing homes, are at capacity. I spoke to two managers of county nursing homes recently who said, you know, they've got substantial wait lists.
Mhm.
And so, understanding there are also private nursing homes in the state, but I guess given the wait lists and the fact that we're talking about Medicaid, which means they're probably, you know, there's a good chance many of them are landing at county nursing homes. Are we really going to be successful in keeping more people in their home? So you've talked about investing in what I will paraphrase what you were saying. It sounds to me like sort of preventative care, or the kind of care that can keep somebody healthier longer so that they don't need that nursing home care. But how else do you see this, practically speaking, keeping more people in their home?
So again, I'll reiterate that I think, you know, opportunities do exist where you can build home and community-based infrastructure services, and I mean the things you just listed, but I also mean, you know, working with a care manager on medication adherence. I mean, occupational services. You know, Representative mentioned earlier transportation services. Building those kind of high fidelity wraparound services in a community-based setting where at least for a period of time, you can keep someone in their home longer and keep them from a point of decompensation where they require that nursing home setting to begin with. I think really that's the objective.
Okay. Other questions?
No, thank you.
All right. Thank you very much.
Thank you.
And last on our list is New Hampshire Healthcare Association. Thank you. Do you need 2 copies?
She's back.
Okay, she's got one. All right.
Thank you.
Thank you, Mr. Chairman, and honorable members of the committee. For the record, I'm Brendan Williams. I'm the president and CEO of the New Hampshire Healthcare Association. We represent most of the state's private nursing homes. We jointly represent 3 county nursing homes. We also represent assisted living facilities, some continuing care retirement communities, and a pediatric care facility. We were one of the stakeholders in 2016. A bill passed, Senate Bill 553, that created a study of transitioning into what was then called Step 2, our MLTSS, as we call it here. And that committee, I was looking back at it, and I think it probably would give some of the participants here PTSD, but it met at least 9 times as a full committee, and it was reported that there were 6 subcommittee meetings. That doesn't seem wrong looking back at it. So there was a very extensive public process that resulted in this legislature deciding in 2018 to not go to Step 2, to in fact repeal the language that would have otherwise placed us in MLTSS. And today, the New Hampshire Healthcare Association remains opposed to transitioning to MLTSS. At the time that this was being deliberated, I had an article published about MLTSS in the Loyola Consumer Law Review, and I looked at some of the assertions that were being made in support of it and really couldn't find any substantiation for them. I still can't find that substantiation today. In fact, I include in a packet for you a few exhibits, one of which is the experience that Indiana, as a recent state transitioning into MLTSS, has had. They have experienced cost overruns of around $300 million. And the current commissioner there of the department that is like our DHHS says that this is something he never would have chosen to do. That there's really nothing to manage when it comes to the care of a nursing home patient, specifically for an insurance company to add value. And there was another article I did not include it this month in the Indianapolis Star, and it was basically about how this sort of $30 billion foray into Medicaid managed care in Indiana has really been a disaster in the estimation of seemingly everybody, the care providers and the governor, and again, the state agency tasked with administering it. We heard some good words spoken about quality of care, and one of my concerns with managed care is the possibility of claim denials. And I include for you a claim denial that one of my wife's home health clients received from AmeriHealth Caritas. She is 89 years old, and she was admitted to the Elliott Hospital for what they thought was something called Stevens-Johnson syndrome. And basically, that is a whole body rash that can result from medications. And being 89 with a number of comorbidities, she takes a lot of medications. And so the survival rate for Stevens-Johnson syndrome can be as little as 50% if you have a severe case of it, certainly no higher than 90%. So there's a very high mortality risk. And so the Elliott Hospital transferred to Brigham and Women's Hospital in Boston, and the MCO retroactively rejected her care. And I told her to appeal, and of course she'll be successful in those appeals, but this is a story that's often told. There was a study done by the auditor for the state of Iowa upon their transition to Medicaid managed care, and he found that it resulted in an 891% increase in members being illegally denied services or care, and reported contract violations by both MCOs in the program. I heard that somehow managed care is necessary for us to do a better job of funding home and community-based care. I've included another exhibit here which shows that a state like Oregon, and Oregon, Washington, other states have done a spectacular job by everyone's estimation in expanding HCBS services. Oregon also pays a nursing home rate about $300 a day higher than the state of New Hampshire. If this state chooses to invest more money in HCBS, as it has, it is able to do so without the intervention of managed care insurers and without them taking 10 to 15% of what you would otherwise spend. I've heard this curious statistic that somehow we rank last in New England when it comes to the proportion of those receiving HCBS and long-term care. So I pulled data from the CMS website, and I guess you can choose whether you want to believe Dr. Oz or believe someone else, but we actually rank second in New England in terms of the highest proportion of people receiving home and community-based services in long-term care, 83.1%, second only to Vermont. And so I include those charts for you so you can see I'm showing my math. We also, if you look at the data that I provide on the back of the sheet, you'll see that really the only population age demographic that you see a higher proportion of in nursing homes as compared to HCBS is those who are 80 and older. We have one of the nation's oldest nursing home populations, not only upon admission, we're one of the 5 oldest populations upon admission, but also the long stay residents are among the nation's 5 oldest. And so, you know, I've heard a fair amount of nursing home bashing here. I think personally that nursing home lives matter. You know, there are people who don't choose to be medically infirm and need the care that a nursing home can provide. You know, I may not want to go to an emergency room as opposed to a minute clinic, but there are going to be those occasions where medical necessity dictates that level of care. So with that said, nursing homes very, very strongly support home and community-based options because our nursing homes, over half of all the patients are discharged into the community. In fact, our rate of discharge exceeds that of the national average, which again is pretty remarkable when you consider how very old nursing home residents are upon admission in New Hampshire as compared to the rest of the country. So, so we have supported all initiatives that have been out there to increase the funding for HCBS. The department had referenced a concept called dual eligible special needs plans. We have some concerns about that program because it involves Medicare Advantage insurers. The American Healthcare Association had done a survey and it had found that delays, denials of medically necessary post-acute care by MA plans occur daily or weekly for 2/3 of skilled nursing providers. And according to the Kaiser Family Foundation, despite the fact that there's fewer prior authorizations in DSNP only plans compared to all Medicare Advantage plans, the rate of denials was twice as high. And the biggest offer of such plans is under criminal investigation right now by the Trump administration. Finally, in 2018, we commissioned an analysis from a national law firm specializing in long-term care. And they shared the opinion that was expressed by the county nursing home administrators at your last hearing, that a shift to MLTSS would jeopardize our Medicaid Quality Improvement Program provider tax mechanism for all nursing homes, as well as the proportionate share incentive adjustment payments that are made to county nursing homes. That is because under the Code of Federal Regulations, you cannot make these types of supplemental provider payments on a pass-through basis through an MCO. And so the only way to make up for the enormous loss of these funds would be to raise property taxes, because property taxes are what fund long-term care in our state. In close, we respectfully urge you to stand by the decision that was made in 2018 because it was informed by a great deal of stakeholder input to reject MLTSS in New Hampshire. We can provide you with data and further information if needed, and you can always contact me if you need any further information. Thank you.
Yes, and thank you for taking my question. Can you tell us a little bit about what the admissions process is to the average privately owned nursing home?
I think, Representative, and with the indulgence of the chair, since David Ross is sitting here with a county nursing home, perhaps he might be able to speak to that. The admissions process would not be any different for a private nursing home as compared to a county nursing home.
Okay, thank you.
So yeah, I guess I just, I don't have a question. I guess I just have a comment, which is you referred to nursing home bashing. I personally didn't hear anything I think that was detrimental to nursing homes. I know many of us as state reps have toured nursing homes. I've toured the Hillsborough County Nursing Home, and we deeply appreciate the value that they bring. At the same time, I think all of us know that our loved ones appreciate being at home and would love to be at home. So we've all seen that happen. So I think
And
if
we
there was
don't-
any misunderstanding about that, I think we very much appreciate and value the role that nursing homes play in our state.
And Mr. Chairman, I can say as somebody who represents nursing homes, I would prefer to stay at home too, given the option. But that option just doesn't always exist. I will give credit to the department. Unacknowledged has been the fact that they have pursued a federal initiative called Money Follows the Person, in which they actually seek to extricate from nursing home care, divert from nursing home care those who might otherwise be served in the community. And so that effort is ongoing. That's currently occurring. Doesn't need to involve an insurer, but it's currently happening.
All right, thank you.
I do have a concern about the loss of MQIP and ProShare and the resulting increase in county property taxes. I can speak for my constituents, and they are really at the end of what they're going to be able to handle as far as property taxes are concerned. So in hanging on to MQIP and ProShare, how does that affect the budget process for the counties?
Well, you know, if in fact we move to the MLTSS model, you wouldn't be able to have those two things as supplemental payments. I don't know how you could integrate those into the rate. There are states that do integrate the provider tax return into what might be characterized as the basic rate. I'm not aware of states that incorporate something like the ProShare payments into the rate. Again, that is a real creature of federal law, and it's a supplemental payment, and so I don't really see, you know, how that could be integrated into the rate. We're a relatively uncommon state, and I think this fact should be celebrated in having county nursing homes, each county having its own nursing home, Coos County having two. And so were those funding sources jeopardized, obviously the impact upon the state budget would be pretty catastrophic.
Thank you.
Thank you.
Thank you. Okay, with that, I will ask if there is anybody else who would like to testify before the committee. Okay, and then I will ask DHHS, is there anything that you would like to provide in the way of comments, or ask my colleagues if there are questions?
None at this time.
I actually do have one question for Mr. Lippman. Specifically, so I had a question of one of the MCOs earlier regarding the rates, and understanding that these are numbers calculated by the New Hampshire Fiscal Policy Institute. They're not official numbers by any means, but under the CFI waiver, average cost being about $19,000, and under nursing facility care, $98,000. Under a capitation model, is there a distinction between those two populations in terms of the capitation fee?
The capitation rates would be set based on the level of setting that they were in. So there's a rate set, if you will, a price sheet set for the types of settings. I have some, I don't know what the date of the report that New Hampshire Fiscal Policy Institute, but just from the department, some 2023 data, which was about $25,203 for the CFI Home and Community-Based Service Program. And so their number may have been combining some other things, but that's the CFI program. Mm-hmm. And then $70,679. Now, these are 2023 numbers. You know, in 2023, there was a significant rate increase for home and community-based services, and nursing facility rates have gone up during that time. But I think that nearly 3 to 1 kind of concept is a reasonable way to think about it. You know,
okay.
My also, in terms of the percentage, and I don't have the source with me, but in terms of some CMS data that I saw, that New Hampshire's percentage of home and community-based services, I'm not sure I can validate either of them, but the recollection I have is we've become much more normative to the rest of the New England area and the country.
Okay. And I think I heard two different numbers. One was that we're low in terms of expenditure. The other was that we're high in terms of usage, or for the population served. So I don't know if you can shed any additional light on that, but I think I was hearing apples and oranges there.
So I think why don't we get back to you with
Okay.
before next week with
That would be great.
clarifying that.
All right.
Thank you.
Thank you. All right. So with that, I will sort of open the floor to discussion if we want to discuss at this time. Otherwise, we can defer to the 24th. We do have quite a lot of material to digest. And I think, okay, I'm kind of on the same page. Does that work for you?
Yes,
Okay.
sir.
So with that, I think we will re-adjourn on September 24th. I stated the time earlier. I don't remember at this right now what it was, but that will be noticed in the calendar.
It'll be 2 p.m.
2 p.m. 2 p.m. on the 24th, and
10 a.m. on the 29th.
10 a.m. on the 29th. And we will spend a good deal of those meetings, especially the first of those two, sort of bringing together our conclusions and figuring out which direction the committee would like to go in terms of recommendations. So with that, we will adjourn the meeting. Thank you, everybody, for attending.
Yes, thank you.